We're very pleased and fortunate tonight to have our two speakers with us, Dr. David Gardner and Dr. Malgorzata Rajda, both with the Department of Psychiatry. David is a pharmacist and also the Director of Community Psychiatry Research and a co-lead of the Sleepwell Research Program. And with us as well, Dr. Rajda is a psychiatrist and a sleep specialist. She's also the past Director of Postgraduate Education in Psychiatry. And without further ado, I'll turn it over to David.
Well, thanks very much, Andrea. To keep things moving along, I'll just jump right in and give updates on Sleepwell, sleeping pills, and cognitive behavioral therapy for insomnia. And you'll probably hear us refer to that on and off tonight as CBT-I, because cognitive behavioral therapy for insomnia is a bit of a mouthful. So some of you may be familiar with Sleepwell and what it is, but I just wanted to make sure we're sort of all on the same wavelength about it. So Sleepwell is a research and knowledge mobilization program. What we try to do is clinical research, health promotion about sleep and insomnia treatment, make sure that people have good access to first-line care for insomnia, and I'll talk a little bit about that. And in improving insomnia health outcomes, we're really talking about illness prevention. So Sleepwell's been around in one form or another for a little over 10 years now, and it's always had the same objectives. The first one is to achieve better insomnia treatment outcomes with cognitive behavioral therapy for insomnia, or CBT-I. And the second is to reduce the overuse of sleeping pills and their related harms. So sometimes we get mixed up a little bit, and some people think Sleepwell is a sleep therapy in and of itself. It's actually not a sleep therapy. It's the name of our program that tries to help people learn about different sleep therapies and make it easier to access those sleep therapies. And the sleep therapy that we try to support access to is one that people may not know about, which is this CBT-I, which is the sleep therapy. So overall, Sleepwell recommends CBT-I programs, specific ones, and I'll share a little bit about that, and shares information, tools, and resources to support the use of CBT-I and to help people reduce their reliance on sleeping pills. And I'll hopefully try to make it clear as to why we're trying to achieve those objectives. If you have ever been to the Sleepwell website, this should be recognizable. But if you haven't actually been there, there's a few features that hopefully you'll come to appreciate over time. What I'm going to do now, though, is kind of highlight the new components of it. And I'll start off by just mentioning that in the last month or so, we've had about 14,000 people visiting the Sleepwell website and a little bit over 30,000 in the last 3 months. So through a lot of, I think it's just word of mouth, people are beginning to learn about what Sleepwell is, what the website can offer people as a resource for learning about sleeping pills, cognitive behavioral therapy for insomnia, and recommendations for getting access to CBT-I programs and so forth. But there's a few new things. So what's new is our stories component of the website. So we've had Faye's story and George's story on the website for a while now, and they have actually been viewed by over 3,000 individuals for each of those. George's in French and Faye's is in English, but we've added to that. So now we have a stories page, and the stories come from healthcare professionals as well as patients. Some are videos and others are written stories. And we think it's a really effective way to help people start to see themselves possibly in some of these stories and look forward or look towards those individuals in those stories as to how they've lived with taking sleeping pills for decades, able to come off of them, to change their approach to how they manage their insomnia and the effects that's had on them in the long run. Another feature is that Sleepwell is now available completely in French. So Mieux Dormir is the website where you can toggle back and forth between Sleepwell and Mieux Dormir with this little button here, the French-English toggle button. And everything that's in English is now available in French. Another new feature is a web component specifically for clinicians, and it's to help clinicians optimize their use of the Sleepwell website, especially for supporting patients who are considering reducing and gradually stopping their sleeping pills, or from switching from a sleeping pill approach therapy to a CBT-I 6-week therapy, and how to go from sleeping pills to CBT-I, and I'll talk about that in a moment, as well as for people who have insomnia and they just want to learn a little bit more about CBT-I, or they're having CBT-I over a few weeks, and some of the tools that are in the program that you can refer your patients to support them going through that program. And on the right side there are some specific CBT-I training programs, so Queen's, Toronto Metropolitan University, and one in the US that offer CBT-I training for healthcare professionals. And I'll just mention the one by Queen's is offered online as modules, so you don't have to travel at all to access the program itself. Now I'll just move over and talk a little bit about sleeping pills and then on to CBT-I. So this slide has a list of medications or substances that make you drowsy, and they are listed there because we know that people use them for treating insomnia. So the top groups are really the prescription medications. So the first one listed there is zopiclone, and that one is very commonly prescribed across Canada, and it's classified as one of the Z drugs. And a very similar class of medications in terms of how they work are called the benzodiazepines, and they've been around just a little bit longer. And some of you will be familiar with medications like lorazepam or oxazepam or temazepam as sedating medications commonly used as prescription medications for insomnia. There's a new class of medications where there's a couple of options. The class is the dual orexin receptor antagonists. And they've been marketed for the last couple of years, maybe a little bit longer than that. And so family physicians are becoming more familiar with those over time. And then going a bit further back, we have sedating antidepressants and sedating antipsychotic medications that have also been used to treat insomnia. And if we go down one further, we look at over-the-counter medications where you can go into a pharmacy and buy a sedating medication. And then the last row is the natural sedatives, so melatonin and valerian root, cannabis, and alcohol. And I kind of just put them all in one big bucket of sedating medications or substances. And when we think about which is the most effective or the most preferred, the answer is there really isn't a best sleeping pill per se. Across the top here, I've organized them by how long they've been around. So the antihistamines are kind of the oldest. And I show sort of the order of when they were put onto the market, if you will, and started to be used in terms of the oldest, so number one antihistamines, to the newest, the orexin blockers, are listed here. And colleagues from Australia, Germany, and the United States did a comprehensive review of the research of these different medications and rated them in terms of their effectiveness and their overall adverse risk profile and their benefit to risk ratio or profile. And you can see the order changes for each of these approaches to measuring it. And this is why the bottom line is that there's no best sleeping pill per se. And I want to emphasize, no sleeping pill is actually recommended first line for the treatment of chronic insomnia. Chronic insomnia recommendations will come up in a minute, and it's cognitive behavioral therapy for insomnia that is the first line treatment. So let's talk a little bit about how effective sleeping pills are, and then we'll just look quickly at their risks. So when you look across the research of high quality clinical trials, we learn that people get to sleep faster taking a sleeping pill, but they also get to sleep faster in the sugar pill group or the placebo group, substantially faster than they were getting to sleep before they came into the trial. So the net difference comparing one of the Z drugs to the sugar pill is about a 10-minute faster onset of sleep. And when we look across all of the different types of sleeping pills, it's 8 to 16 minutes. When we look overall at how much on average people are sleeping longer in these trials, it ranges between 5 and 23 minutes. When we look at the risks of sleeping pills, there's a couple of things I just want to mention. The rate of sleeping pill use increases with age. It's quite low in teenagers and young adults overall in the population. The rate of use is low, and it goes up like a staircase. With every 5 to 10 years, you go up another 5 or 10% of overall use. So by the time you're in your 70s or 80s, there's about 30% to 40% of individuals who are regularly using sleeping pills. And I have to add, the risk of adverse effects, serious adverse effects, also goes up with age. And so I've illustrated here some of those risks. So injurious falls increases by about 60% when taking sleeping pills. And that includes fractures or broken bones and hip fractures as well. They also have an effect on our immunity. So if we get the flu or COVID while we're taking sleeping pills, we're at increased risk of complications. They affect our memory, so cognitive impairment, decreased alertness. This is next day decreased alertness. They can interfere with our ability to think, and there's evidence of a relationship with cognitive decline. Also, we're concerned about their effect on next day driving. Canada's most commonly prescribed sleeping pill is Zopiclone, and it has an effect 11 hours after taking it, which is the same as a blood alcohol content of about 0.08, which is an illegal level of blood alcohol. So some sleeping pills have a profound impairing effect on driving the next morning. And then lastly shown here is the issue around the vicious cycle. You take sleeping pills, you take a substance, you take cannabis for a while, you find it helps you to sleep, and then you say, I'd like to see how I do without it. If you stop, the first thing you see is poor sleep, a rebound of insomnia that can be even worse than you remember it being. And so coming off of any sedating substance can be difficult and should be done gradually to minimize the rebound insomnia and other withdrawal symptoms that can happen. So how do we actually stop sleeping pills effectively and safely? And so that's one of our overall goals, is to support people to reduce and stop their long-term use of sedatives. And there's three magic words: gradual dose reduction. And what you see here in this overall kind of schematic is we're looking at taking several steps of lowering the dose over time, and that often translates into weeks or even months of gradual dose reduction. People do it at a rate that they're comfortable with. Some people can do it quicker than others. The vast majority of people are able to very gradually come off of their medications successfully and not need to take it longer or go back to it over time. If you do it too quickly, you will probably experience some rebound insomnia, and a small proportion of people may experience some other withdrawal symptoms. We have the Stop Sleeping Pills Guide, and it's available online on the Sleepwell website, and the Stop Sleeping Pills Planner to individualize the plan for coming off of the sleeping pills. So there's general advice given so that people learn the overall process and can individualize it. It depends on how long you've been taking sleeping pills. That'll affect how quickly you come off of them. And just to sort of illustrate this, you can work with your healthcare provider to come up with an overall plan. So if you're taking Zopiclone, say a tablet and a half, and you want to gradually lower it, you can work with your prescriber and your pharmacist to come up with the plan, and then you can write down the plan as it's unfolding for you. So they may give you some advice for the first 4 weeks of how to reduce the dose, and then you write down the actual dose and how you decreased it over those first 4 weeks, because everything doesn't always go according to plan, and you may have to adjust things. You can continue with a new plan for the next 4 weeks and write down again how you're doing that and track how you're doing it. But most importantly, we encourage you to work with both your prescriber and your pharmacist to come up with a practical approach for yourself. And then ultimately, your plan may look something like this over time. And a question that we get often is, what if I want to use cognitive behavioral therapy for insomnia so that I can improve my sleep while trying to come off of my sleeping pill? And that actually is usually a very good idea. And some people like to start the CBT-I program, and it's usually around a 6-week program here. So it may take longer to come off of the sleeping pills, but you can complete the CBT-I program as you get started on the decreasing of your sleeping pills. Or you can wait a little bit later until you feel like your sleep is not so good at lower doses or even very low doses before you start your CBT-I program. And you don't have to do a CBT-I program to successfully come off of sleeping pills. You can wait and see. And if you notice that your sleep is not as good as you want it to be, you can always do a CBT-I program after you've come off of sleeping pills. So I've mentioned CBT-I an awful lot. And so I'll go quickly into what CBT-I is and sort of cover it from a higher level. And Dr. Rajda is going to talk to you a bit about a specific component of it. So CBT-I is considered to be a multi-component therapy or program that gives you a whole range of sleep-enhancing techniques. So when CBT-I was first developed, it brought together different techniques. So stimulus control, which with Sleepwell, we just call it control, along with time and bed restriction therapy. The two of those are the behavioral components, where you take control over what time you get into bed, what you do when you can't fall asleep when you're in bed, and how you may actually limit your time in bed so that you find that you're really so tired that you're sleeping in bed instead of lying in bed awake. And that really can change your relationship with your bed and limit or reduce the arousal, your brain racing, your thoughts racing while you're in bed. And then there's other components such as relaxation therapy and cognitive therapy. And then the final one listed here is sleep hygiene. Sleep hygiene is really not considered a critical component of CBT-I. Sleep hygiene is an important component of short-term insomnia, where you may make changes during what you do during the day or as you approach the bedtime, getting your bed comfortable, your room at the right temperature and low light, no caffeine later in the day, try to minimize naps. But if you have chronic insomnia, you've probably tried all of those things, and it's time to focus on a complete CBT-I program involving these other components. And this just kind of shows you a schematic of a typical or average CBT-I program. You use a sleep diary to track your sleep. So each day that you're in your CBT-I program, which in this case, it's showing over 6 weeks, you complete your sleep diary, and that takes about 1 minute to 2 minutes in the morning. And then you build your skill set, if you will, using new or additional sleep enhancing techniques. So sleep hygiene, you may already have some of those and you can get reminded about them. And then stimulus control, and then to build your sleep drive, time and bed restriction therapy gets added on in the second or third week, and then some relaxation techniques and some cognitive techniques are added on. And by the time you get to your 5th or 6th week, you'll have noticed that your sleep has substantially improved through that process. And then the program ends. And the research on CBT-I, whether it's from a therapist or from self-help, shows that it's effective long-term, many months or even years after ending your CBT-I program. The evidence comes from all parts of the world on the effectiveness of CBT-I, and there are guidelines that say basically the same thing from all around the world. And so I'll just read the middle one from the European Sleep Research Society. CBT-I is recommended as first-line treatment for chronic insomnia in adults of any age, and a pharmacological intervention can be offered when CBT-I is not effective or not available. And so we have a few different tools and resources to share information and compare, in this case, CBT-I and sleeping pills. So if you're a healthcare provider, this may be something you'd like to have on hand and give it to your patients so they can contemplate the alternative to sleeping pills. And just one of the last things I want to mention about the website is that we recommend specific CBT-I programs. Some are in book form and some are apps, but they're all self-help. So over here on the Insomnia Step Care model, we're really trying to help people not necessarily feel the need to see a primary care provider or go to a community pharmacy for specific therapies. They can do it on their own, including for chronic insomnia. These are evidence-based interventions that are really self-help interventions. So I welcome you to visit our website for that. The last thing I'll just mention, and Andrea alluded to it, is the research results that have been published related to the Sleepwell intervention. We did a 3-group comparison study of Sleepwell to Empower, which was a set of brochures that had been studied to try to reduce the use of sedatives, to a third group, which was treatment as usual, so no package. So the contents from the Sleepwell website were sort of repackaged into booklet forms. And so the people who were randomly allocated to the Sleepwell group received this package. So a cover letter from Dr. Rajda and I, and the Sleepwell booklets, how to stop sleeping pills and how to get your sleep back. We didn't do anything else. We left everybody who was in this group for 6 months and contacted them. The research assistants contacted them to assess their use of sleeping pills as well as their sleep after 6 months. The people in the study were older adults, all over 65 years of age. All of them were independently living, so none in nursing homes or long-term care facilities, with a variety of health issues and taking different medications. The average duration of sleeping pill use in the study was over 11 years of use, and about 31% of them had had a fall. A fifth of them had a serious injury related to the fall prior to coming into the study. So that gives you an idea of who was in the study. And here's what we found. that the booklets themselves were associated with 26% stopping sleeping pill therapy over 6 months, which was more than in the Empower group. And another 20.4% reduced their sleeping pill use by more than 25%. So almost half of the individuals who received the package of booklets, the Sleepwell package, had either stopped their sleeping pill or reduced their sleeping pill. Now, the other question is, what happened to their sleep? We saw in the Sleepwell group their CBT-I technique use increased, their sleep onset improved substantially with almost a half an hour faster onset in sleep compared to the treatment as usual group as well as the Empower group, and other benefits on sleep efficiency and insomnia severity, reduced daytime sleepiness. So we were very happy to see reduced use of sleeping pill use and better sleep outcomes. So I'll just end with my section and pass it over to Dr. Rajda by letting you know that we now have an active resource center where you can access any and all of the resources that I've mentioned. So our booklets are now available. We've made them so that the money that is charged for them is basically only cost recovery, and the money that comes in will allow us to be able to purchase more at bulk prices and sell them at bulk prices on an individual level going forward. So we're happy to be able to let people know that they're now available online in a couple of different ways. And now I'll pass it over to Dr. Rajda.
Thank you, Dr. Gardner and Dr. Murphy, for your kind introductions. I am going to talk about the part of cognitive behavioral therapy for insomnia, which focuses on our thinking, and that's the cognitive part. So before I start, let's reflect for just a minute. Think about the last time you were in bed and could not sleep. Can you remember what you thought about, perhaps you worried about? And when you think about those things, think about how did the worry make you feel? Or did the worry and the associated feeling help you to sleep better? So the worry and the thinking about sleep probably did not help you to sleep any better. And this is a well-known phenomenon which forms the basis of any cognitive behavioral therapy, where we recognize that the unhelpful thoughts that we are thinking affect our feelings and affect our behaviors. So, for example, when we think positive thoughts, we are more likely to experience positive emotions and engage in healthy and positive behaviors. And vice versa, if we are thinking thoughts that are not helpful, that are negative, we are more likely to experience negative emotions and more likely to engage in behaviors that are not conducive to positive emotions. And it becomes quite a vicious cycle. So that is exactly what cognitive behavioral therapy is about, or at least what the cognitive part of it is, to address those unhelpful thoughts. So when you think about when you are in bed, lying there and thinking and perhaps worrying, are those thoughts helping you to feel better? Are they helping you to sleep better? And how they affect the things that you will do at night and then during daytime? When we are dealing with that in cognitive therapy, we have several different tools and techniques to address it. One of them, an example, is a paradoxical intention, where we work on interrupting the negative thought pattern or shifting our focus in our thinking pattern. When we think those negative or unhelpful thoughts, it will cause us to feel more awake, perhaps upset, perhaps frustrated, and we try harder. And we try harder to sleep. And when we try harder to sleep, it makes us feel more anxious, because that's, again, fueling all those thoughts. How am I going to function tomorrow? If you remember one of our poll questions. And many people will agree with that. Oh, if I don't sleep well tonight, then I won't be able to function well tomorrow. Well, that kind of statement to oneself is not very helpful, because it is not going to help us fall asleep faster. So in this example, we would use efforts, we would make efforts to shift the thinking pattern and reduce the intention to sleep, make us not try as hard to sleep in order to reduce the arousal, reduce the upset and the negative emotions, and help us to fall asleep faster. As part of this talk, I want to mention a challenge that myself and many of my colleagues providing cognitive behavioral therapy for insomnia are encountering. When I was starting this work, we didn't have the commercial devices that there are now. Now, most patients will come with something on their hand, on the wrist, or they are using other devices. They can be wearable, they can be nearable, so something that they place near their bed, and they derive information about their sleep from those devices. I have certainly seen people who requested a referral to the clinic because their commercial tracker was telling them that they are not sleeping well. And it's not uncommon that people will start the session with talking about their devices and the information they obtain from their devices. So where is the problem? In therapy, we use sleep logs because what really is important in describing your sleep is not so much what the device tells you, which may or may not be accurate, and I will go back to that later, but what is the person's subjective experience with their sleep. So why would you ask, is this a problem? Well, by definition, insomnia is a set of subjective symptoms. It's subjective experiences, and those don't necessarily equal the data from the devices. Has anyone ever been surprised by the difference between their device and their actual experience? That's a question for those who are using those devices, and I'm sure many will say yes. But in clinical practice, what is the problem? Here it is. It's a huge market. In 2023, so just over a year ago, it exceeded $2 billion US dollars. We don't know about Canadian population exactly, but it's estimated that about 30% of people in the US are wearing the devices. I don't know what is going to happen now, whether Canadians are going to continue using the devices or not. But there is a predicted steady growth. They are here, they are very popular, and the manufacturers of those devices make a ton of money on selling those products. So those devices claim that use of the devices to monitor sleep will lead to an improved sleep. How can that be? So because the devices are supposed to provide a lot of information about sleep and their sleep patterns and track cycles, and they claim to detect sleep stages, but most of the time they present it in terms of words like sleep quality, sleep depth, or sleep score. What those terms actually mean, we don't know, and I'll tell you why this is a question. So as a sleep physician, I define sleep characteristics based on the electrical activity in the brain, in the muscles, and in the eyes. That's how sleep stages are defined. So some people may have heard about us talking about sleep stages, about deep sleep, superficial sleep, or REM sleep. Those terms have very precise definitions based on the electrical activity in the brain, muscles, and eyes. Now, what about those sleep trackers? What do they actually measure? Well, most of them will measure movement. That's a given, and this is the basic technology. When we are moving, the devices can detect the movement. And it's generally accepted that when there is more movement, there is likely wake. So a person who is not moving is probably asleep. Although we do have data suggesting that people with insomnia can spend quite a long time lying down without much movement. Those devices can also measure other physiological measures such as heart rate, variability of the heart rate, photoplethysmography, or other things. Some of them, if they are put under the mattress, they can measure some respiratory effort or movement. So those are the things that they measure. Those devices do not measure electrical brain activity, electrical muscle activity, or eye movements. Another question about the devices that we need to be aware of, that the sensors that the devices are using are proprietary and they are not in public domain. And what you see is a standard for measure for 1 meter. This standard is kept in a special laboratory in France, near Paris. And if I want to know if my measuring stick measures exactly 1 meter, I can take my stick, go to France, compare it to the standard, and hope that my stick measures up to the standard. So we can compare it. But if the device sensors are not in public domain, we can't actually determine. We have to trust the manufacturers that when they are saying that this is what it does, that's the case. Also, then the data from the sensors are analyzed by use of an algorithm, which is also proprietary and not in public domain. And the algorithm analyzes the data and provides an output. And this is the information that we get from the device. Once again, that is information that is how the device arrives at the information that it gives us is not necessarily in public domain. It is rather difficult for me or Dr. Gardner to go and evaluate this and validate it. So in the end, we do not consider those devices, the trackers, to be medical devices. They are not regulated, and they are the manufacturers have the option of conducting studies to validate the technology, but it is entirely voluntary. So do the trackers measure the same thing? Well, I'm not so sure, because they actually have different sensors and they measure different physiological parameters. The trackers don't necessarily take into consideration effect of various brain disorders, medications, or substances that people may have on board, and how it will affect the physiological parameters and how it will affect the data that the devices are providing. And finally, I am not aware if those trackers were validated in different populations, and so can we compare those apples to oranges? But having said all that, are they no good? I think the fact that we have millions of people using the devices and constant efforts from the manufacturers to improve their performance, I think there is certainly room to consider their use, where they can be helpful. They can be helpful to identify sleep habits over longer term, because they measure activity. So we can see over longer term how much is a person active versus inactive. And what about patterns? What about patterns related to the body clock, what we call circadian patterns? So this can all be helpful in considering an individual's behavior. But I think we have to be very careful how we interpret the information. Let us circle back to the question of thoughts, helpful or unhelpful, and sleep. Some people, especially those who have difficulty sleeping, will spend much effort on optimizing their sleep environment, even people around them, in order to achieve a good night's sleep. So no wonder that such individuals will be very interested in use of the trackers. Sleep trackers promise to improve our sleep by examining those minutiae of physiological variables, but some people can overdo it. A few years ago, a term orthosomnia was coined, and which was defined as obsessive pursuit of ideal sleep, which is free of disturbances with regular sleep cycle. Sounds like a dream. But when a person becomes overly preoccupied with analyzing the data, with optimizing their sleep conditions, and constantly checks the data, that can actually be counterproductive and interfere with achieving good night's sleep. Because the devices may overestimate or underestimate our sleep information, and people will come to rely on those devices to tell them what is happening, they may experience more stress and more arousal. So if my Fitbit tells me that I'm sleeping poorly, no matter what my personal experience is, I'm going to think that I'm sleeping poorly. And that in turn will lead to increase in worry, increase in my negative thoughts about sleep, and interim worsening of sleep. So let's go back to the first slide where I asked you to reflect on the last time you were in bed and could not sleep. And you were worried. So tell me now, did your worry come true? And reflect on what happened the next day. Did the next day turn out as terrible as it did?